and got everything nice and wet and soaked, which is great for the for all my plants out in my backyard. And but it's turned into a nice day, a little bit breezy, but sun's out and things look good here. So we are on the last section of the pharmacology course. So basically, we're going to finish up today, and that'll be another course under your belts, which will be good for you guys. And I think probably, in my opinion, and again, it's a little biased, but in my opinion, probably the pharmacology course is probably the most difficult. The physiology course you guys did pretty well in. There's people over the years that I've taught this. The physiology has been, there have been certain sections that have been a little rough for different sections, but with pharmacology, it's not that it's so difficult. It's that there's just so many drugs, so many different classes of drugs. And we have taught this over the years, which I think has made a big difference in the states that we, that they have gotten prescribing rights for looking at it, because it's easy to say that we're teaching you guys pretty much the same pharmacology that we teach pharmacy students and medical students, but then you guys have one more series, which is dealing with the advanced pharmacology, and we go in much more depth. And although we go in much more depth with regard to the other courses that's coming up, the thing that makes it a little bit easier is the fact is many of you have dealt with patients that are on those particular drugs, and you have a little bit of an understanding and more familiar with the drugs. But with a lot of the drugs here, you may have heard of them, but we've covered classes which some of you may not have ever dealt with there. So with the advanced pharmacology course, to answer your question, Rebecca, the advanced pharmacology course, basically what we do is that we go into, so for example, when I talk about anxiety, I'll go into the first part of the class will be sort of reviewing some of the issues and theories of that. For some reason, I'm getting, let's see, there's an ad that popped up here. I don't know why it popped up, but let me get rid of it. Can you guys still hear me? I'm not sure if the...
Yes.
Okay, good. Because it looked like this was starting to relaunch Zoom or something like that. But to answer your question, Rebecca, the thing is with the advanced courses is typically what I will do. I will teach the anxiety, I teach bipolar, I teach the schizophrenia, and I do teach one of the days on chronic diseases. But for example, with anxiety, I'll go over the basic theory of how anxiety occurs. So we'll talk about the basic pathological mechanism and how the transmitters evolve, which sets up the point of the targets that we've used pharmacologically. And then we will go into the drugs. What we usually do, or I usually do, is throw in 2 or 3 case studies, case reports that you guys will work on. And so I'll give you instances, for example, with somebody on a benzodiazepine. So we'll talk about, the mechanism of, say, benzos, the mechanism of some of the SSRIs that are used, identifying endpoints for therapy, identifying what side effects you would expect, possibly how to deal with that. But what I've seen over the years is that most of the students seem to do pretty well from a standpoint on those materials, because one, and actually I saw this when I was getting my graduate degree, the people that, when I was taking pharmacology, there was a number of pharmacy students that had been working in drugstores. And those people that were actually working in drugstores actually did better than the students that weren't doing it, because they could recognize the side effects. They could sort of put a name to somebody that was on a particular drug for this sort of thing. So we'll talk about some off-label uses. We'll talk about some, we'll also include like herbs and supplements that people have used and provide you with that. But what I've basically found is in the advanced courses, the students generally just feel a little bit more comfortable. The material's a little bit more in depth, which it should be, But what I've found in general that the students, most students have had experience treating patients with depression, anxiety. We will talk about comorbidities. We'll talk about, rule outs with, for example, with bipolar and schizophrenic patients, there's substance abuse there. So what I've found is that although we go into more depth, the students are usually more comfortable with it. And you get a lot more depth than the MD students do in their general pharmacology. So I think you can be confident with regard to that. So right now, I think the biggest thing is with most of you, and keeping in mind that, you guys don't have an 8 to 5 job and you have families and, you're working a job and coming back to school. You've got all of those things that add to, and then we're throwing a lot of volume to you. But we found that this curriculum does work. And some of the headaches that we've run into in the last semester and even a little bit in this semester, I think Dr. Steinman has been doing a real good job we've had some things put on us that is because of Alliant University, and it's not unique to Alliant. It's happened here at Georgia. It's happened in a lot of places. So from that standpoint is hopefully we will decrease that. And I think moving to Zoom has taken care of a lot of that. So, and some Brady, your point is that you're going to, and I tell all the students, there's almost no way to not use some memorization. But one of the thing is that you will find that just like I give you guys some slides and I say you're not responsible for you, it sort of sets up. What I would do if you've got the summer free is personally, I would just sort of look back over my notes and I hear this from almost every class. I shouldn't say almost. I hear it from every class. Every now and then we have, 1 or 2 people that it's like, oh, pharmacology is very easy. And I will tell you, I'm a pharmacologist. I've been teaching this for, over 30 years. And I will tell you when I learned it was when I started writing lectures. That old thing is, to learn it, do it as if you're going to teach somebody. And most of your instructors, I would be willing to bet, if they're honest, would say that when they really learned it is when they sat down and organized it so they could explain it to some others there. And so, in general, you're going to be focused on more of these drugs more in depth of the drugs that we're going to talk about in your advanced courses. But you need to know the basic pharmacology and be familiar with these other drugs. Just like, for example, with pharmacy, what we do is the kids get they buy a pack of, they're called drug cards. And they end up memorizing, spending a lot of time taking these drug cards, if I have time, I'm going to try to develop some, quote, drug cards for psychologists and psychopharmacology, which basically will give the drug, I did this actually for some psychologists here in Georgia who were working in the school system. I actually developed some drug cards, and we actually were going to put it on computers so we could update it, but they had computers, but they couldn't access Wi-Fi where they were at. So we ended up just making a booklet for them, and they found it interesting because basically I covered basic mechanism of action, major side effects, indications, both off-label and on-label, and then I had pictures of the generics and so forth so they could see that. And so the concept is that soon I would be hopefully be in a position to get that done in your class, maybe one that would potentially, have access to those. But I'm trying to finish up a textbook on drug abuse and for my class, which I'm a chapter behind now, but I'm going to try to do that. So Danielle, those farm flash cards, those are on there. And they do have some. What I was hoping to do is to focus on just the drugs that you're going to do it. The other thing, there is a drug card. They just do the top 300, and that's what our students have to get. So there are some flashcards out that have some information. The question is, do they have all of that? We don't use them for this course because I think it would just be an extra burden of cost and so forth for you guys. But anyway, be aware that that there is, that even after this course finishes up, and I'll be seeing you guys for at least 3 or 4 more weekends in the future. But if you have questions about pharmacology, don't hesitate, or even the pathophysiology. I have former students that send me emails and so forth, and so I'll be more than happy if I can provide additional information. And I have not forgotten about the kratom and the CBD, but I will put that up and get that going so that you guys will have that. Okay. All right. So let's go over the questions that we had yesterday. All right. Let's see. All right. So question set yesterday afternoon. The first question. This would be a good question to make sure you are comfortable with. Good chance it might show up again, but it's good information to know. So question number 5 was NSAIDs can interfere with lithium's hepatic metabolism, raising lithium concentrations. Okay. And the correct answer is false. Now, I want to point out something to you, this is where sometimes you read part of a question, and especially if you're going to take the PEP or something like that, and PEP doesn't have any true false questions, but there are a lot of times we'll put something there which seems like it's leading you down a path, and then it makes a twist. So the key to this question, and I wanted to point it out, it wasn't made to, I don't write these questions up in a sense to intentionally trick you, but I want you to catch a key point. So the reason this is false is basically because it has hepatic metabolism here. If I were to make this question, because lithium does not go through the liver, and we will recover that when we talk about managing mood disorders and so forth. So the reason this is false is because NSAIDs can interfere with lithium's hepatic metabolism. If this was written, NSAIDs can interfere with lithium's metabolism or excretion and raise the lithium content, then it would be correct. But the big difference is NSAIDs will go through the liver, but lithium will not. Okay, so question number 6: analgesic effects of opioids are mediated by which receptor? The answer is B. That's the mu receptor. The kappa receptor, there are some aspects of where some people suggest that it may have a part in some drugs, but primarily most of the opioids, their analgesic effects are mediated by mu receptor. 7, the most common cause of death with opioid overdose is, and the correct answer is B, respiratory depression. Okay. We do have some people that sometimes will can die because of cardiac problems, arrhythmias, but majority it's respiratory depression. And question number 8, tolerance occurs with all opioids. The answer is true. So all of the opioids will produce tolerance. Tolerance may vary between individuals, may sometimes vary between the different opioids. So, but it will develop to all of them. Now, remember yesterday we talked about tolerance to all of the effects does not develop. For example, 2 effects in particular, meiosis and constipation, typically do not develop tolerance. People that have been taking opioids still will suffer from that. Okay. So I went into a little bit more explanation than just the answers, but hopefully that will get you guys, would just help you with your studying and everything. All right. So let me move to the slides where we left off. And let's see. So we had been talking about hormones. And prior to this, we had talked about the morning after pill, which is, again, just emphasize that it has to be given within 72 hours post-coitus for it to be effective. The effectiveness drops off majorly after 72 hours. We have had people that take it, a week or so afterwards and have gotten pregnant. We've had people that have taken it after, a week or two past it and said, I didn't get pregnant and think it works. Just remember that every act of intercourse does not necessarily result in, conception. So some people that did not get pregnant, the thing is it may have just been they weren't going to get pregnant regardless of what they did. But sometimes those individuals will say, oh, I've used it. You know, I've even had a couple of patients that I'm aware of that had said things with regard to, you know, have asked me, or not the patients, but the treating physician has asked me and says, well, the patient says they've been using this as a form of birth control, and, you know, it's been effective even though they've used it after 72 hours. My response is to that is then that was not pharmacology. That was luckology. It was basically, it wasn't, you know, the things were not right for them to get pregnant at that particular time. Now, another thing hormones have been used has been for contragestation. Mifepristone is actually a synthetic potent antiprogestin that blocks or binds to the progesterone receptor. This one has been sometimes used as an abortifacient. RU486 used to have, there was a lot of controversy over whether this should be available. Generally, that is well tolerated when it's used for this from a pharmacology standpoint, but there is some occasional prolonged uterine bleeding that may occur. You know, again, there is a lot of controversy. I had one faculty member that did not, he did not believe in oral contraceptives, and so he wouldn't teach them. And he would start in with regard to, when he got to that area, he would give his moral beliefs as to why they shouldn't be used, and therefore he wouldn't teach them. And I had to have a conversation with him, is whether he believes in them or not. These students, if you can imagine pharmacy students walking into a pharmacy and not knowing anything about oral contraceptives. I mean, they have been one of the major, you know, things that we've seen, you know, basically, we see these prescribed all the time. In fact, a lot of, I know at some of the small college towns is that the local pharmacies, the small pharmacies close, that brings in a lot of customers because the co-eds come in to get their birth control pills, and then they're buying things out too. So, it is, you know, we have to explain to them. And by the way, the other thing, I agree, Eddie. I mean, that's one of the big things that I've tried to tell them is that our classes basically, as well as, you know, healthcare and everything. One of the things we went through, you guys may be too young, but there was a big national issue that occurred several years ago where that a pharmacist refused to fill a woman's birth control pill, and she was suing the pharmacist. Do you guys ever remember seeing about that? Yeah, Angela, you did? Okay, so you did. Okay, so here's the thing. From a pharmacist standpoint, they are under no obligation to fill a prescription. And I say that from a standpoint based upon the law. All right. So if a pharmacist chooses for personal beliefs, let's take that pharmacist. If the pharmacist had personal beliefs and does not believe that morally that birth control pills should be dispensed, that pharmacist is not required by law to fill that prescription. But here's the thing, and ethically, you know, they could argue that their ethics or their ethical beliefs basically would say that. Now, if you were dealing with, you know, we run into this sometimes with individuals, for example, needing blood and things like that. One of the things we run into is like their religion says they can't get, you know, transfusions and stuff like that, and you have to basically abide by their beliefs. But getting back to the pharmacist, is where the problem occurred is that the pharmacist kept the prescription. That's where the issue became, because the prescription, when the woman handed him that prescription, he could have simply said, I do not believe birth control pills should, or I'm not going to fill this, my own personal belief. He could, whatever he wanted to say. But where the issue came, he kept her prescription. If he had returned her prescription and said, we're not going to fill this, then basically she could have gone somewhere else and got a prescription. Okay. So where he crossed the line was really by keeping her prescription. All right. Now, a pharmacist can keep a prescription or take a prescription from a patient if they perceive and have good evidence. For example, it's a forged prescription. So we can keep it then. I mean, pharmacists, basically, we tell our students, if you have good reason to think this is a forged or false prescription, you can keep it. And we have seen things like, a person comes up and has got a prescription for, it looks like 9-oxycodone, and these are Schedule II drugs, so there's no refills. You have to get a new prescription each time. So we have had people show up, and under the refills, where there's been 0 written, the person has put 10, made a 1 beside the 0. Well, pharmacist knows you're not going to get 10 refills. We've even seen them stupid enough that basically where it's in a different color ink than the 0. And we've seen the 10 written, the 0 being in blue ink, the 1 in red ink, and then up there where they were supposed to get, 90 pills for a month, it's been changed to, 290 or something like that. Again, the changes have been done in different color ink. We've actually seen that occurring. Okay, so we can keep the prescription, but basically when it comes to, and RU486 was another one, is what, somebody may not want to dispense that. Now, here's the thing. This is what we tell our pharmacists. By law, you don't have to dispense these medications. However, if you're working for CVS or Walgreens or Rite Aid, if you're going, I'm not going to dispense any birth control pills, well, those particular pharmacies might simply say, well, that's fine, you're not working here. So just because by law you're not required to fill a prescription doesn't mean your employer is going to be comfortable with you filling that prescription. So we tell the students, so by law, as long as you give the prescription back, if it appears to be a legitimate prescription, then you've done nothing illegal. However, that doesn't mean that your employer is going to let you continue working there, because they may be making a lot of money when they're filling those prescriptions. So just a point there with this regard. All right. So, well, actually, when you ask Jason the question, the employer can't force a pharmacist to fill a prescription. Basically, they can't say you have to fill that prescription. Correct. They can say, if you're not going to fill that prescription, you're not going to work here. So they can do that. Right. So, and the other thing a lot of people don't understand is, and we even see this with some of our students, is they go into sometimes, like, they even get good ways into pharmacy school, a year or so into the curriculum, before they realize some of these people think that, let's take CVS since you mentioned it. They think that who's in charge of the store is the pharmacist. And several of them have found out that the pharmacist is in charge of sort of the medication stuff, but that pharmacist is actually hired by CVS, and the manager of the store may be a 21-year-old business major that has no experience with pharmacy. And I have seen pharmacies that have gotten into trouble because the retail store will not hire pharmacists because they're trying to save money, and when they've gotten overwhelmed with all these customers coming in, they've actually pulled other people and put them in the pharmacy to try to work. Those have that would be illegal, because those people can't just come off from the front cashier and start filling prescriptions. So we've seen some strange things. All right. Now, let's talk about one group of patients you will look at is people with postmenopausal. And so what we do see is that with postmenopausal, we do see hormone replacement therapy. How many of you potentially have or have patients that are on postmenopausal, that are on hormone therapy? Women, postmenopausal women. Do any of you have patients like that? The reason I'm asking, okay, so absolutely, a lot of meds for this. You have a few. Okay. All right, so several. So from a standpoint is, how long have those patients stayed on that? Have they been on it? Do you have any patients that were initially started on it and are now, have quit taking it? Just out of curiosity. Okay, so most of you, the patients seem to be compliant on there. Um, Kirsten, some of them are afraid because not only the hot flashes, but other things there. So, right. Okay. So I was just curious because one of the things that we find in is that what we've done is when people have gone through menopause, basically what you've gone to is a hypoestrogenic state. And so a lot of side effects come up. But what we have seen is that, and so typically we are going to recommend putting them on estrogen therapy. We found, in particular, one of the big reasons or one of the big drives of putting them on estrogen therapy is not only from a standpoint of alleviating some of the symptoms like hot flashes we see there, but one of the things that you have to worry about sometimes is some of the hormonal, excuse me, some of the hormones may actually produce other side effects. And sometimes we've had women that have started on them and then gone off of them because they don't have the side effects. When my mom was put on it, when she went through menopause, the first preparation they put her on, the problem was it created some side effects which she had a hard time dealing with. So literally, her doctor sat her down and said, "Okay, we can change this, but it really is going to come down to that you're probably going to have certain side effects versus with each one of them, and you need to decide which side effect you can tolerate." My mom, the first one, the hot flashes, she worked at a bank. She was an officer in a bank. And one of the things that we seeing is that that it was when she was in meetings that it would just feel like, I mean, she'd get very claustrophobic. It made it very difficult to sit in a lot of meetings. But he basically said, well, we can try different preparations. So they basically moved things around and tried different things till they got one which she had some tolerable side effects. What we found is that with estrogen replacement therapy is that it's the estrogen is, especially with taking care of some of the loss of the estrogen. But one of the big things is osteoporosis. We found really that by putting them on there, the biggest thing was that estrogen was actually better at preventing it. So that's one of the reasons we wanted to put the women on there, as they very early on, because it is not a very effective drug at reversing the osteoporosis. So it's more preventative. And so, again, some of you mentioned, some of you were there, mentioned some of the side effects. Hot flash is a very common one. The other thing that we have seen as women have stayed active, much older, we see a lot of commercials now about things. We do see genitourinary atrophy, and that can be very painful sometimes with regard to their sexual function. So that's another thing that occurs. And we also found that the estrogen was sort of protective. We found that it lowered the LDLs and elevated the HDLs, which was a good thing. And in fact, what we think may be happening is the exact mechanism by which estrogen does that is still a little controversial, but estrogen may also have some free radical scavenging properties. So that's another thing. So it's recommended that you start therapy pretty much with the onset of menopause. Now, one of the questions is sometimes individuals have difficulty determining. I've had women that basically, I've told my students this, we've had women that basically said, well, I think I'm on my third menopause. So we can take blood values and we can pick up information, as we talked about in physical assessment, so we can monitor and come into play with that. Progestins, on the other hand, actually, they have, as I said yesterday, they have some negative effects on lipoproteins. So if we use progestins, we want to keep that dose pretty low so that we don't get the cardiovascular, the disease. In particular, we're worried about the LDLs going up and the HDLs going down. One of the things, as I mentioned yesterday, is that by reducing and lowering the dose of estrogen that we're using, we have been able to reduce some of the side effects. Like when my mom was taking it, they were using still much higher doses of estrogen than what they're using now. So what we found with those higher doses, we saw more women that would go off of them because of the side effects. I mean, many women with these higher doses of estrogen, we saw a lot of them would complain about being nauseous almost every day. Many of them could handle that, few couldn't. Probably the bigger things was they complained of the abdominal cramping that can occur, some bloating. Many of them had diarrhea. Some people, some of the women complained of breast engorgement, which was painful. And that was significant enough where that, for example, it made it very uncomfortable for them to wear a bra. And so that was an issue. We did see some mood changes. We did see some people had some vision differences. Most of these, we were really trying to see which sometimes it would be, which side effect can you really deal with? But we've dropped those doses down and we've reduced these side effects. Still with estrogens, we do have some concern. We have to be careful about high blood pressure. As you get older, one of the things it's going to be is that you may be already hypertensive. This may raise your blood pressure a little bit higher. Still have a concern about thromboembolic disease. So we have to weigh a benefit risk as to whether you should be on these, depending on, other things. There has also been some concerns with regard to the issue with regard to endometrial cancer and gallbladder disease. One of the big things is sometimes gallbladder disease can be pretty painful. Kirsten, the issue, the ERT, is that basically the recommendation is to stay around 10 years, but what we see is we see individuals, especially with the estrogen replacement therapy, if it's estrogen alone, we have seen people that have gone on it for longer than 10 years. There's monitoring. We have seen people that have come off earlier because of these concerns. So I forget what the label says off the top of my head, but the point would be is if you exceeded what the label said, it would just simply be off label. And I do know there are women that are on these, have been on these drugs for a pretty significant time. But again, one of the things you have to look at is the effects on blood pressure, the effects on the cardiovascular disease with these. Now, another use of this, and I may have a couple of these slides sort of mixed up, is we have used hormonal therapy to induce ovulation. This is typically, we see a large majority, I mean, we see about 20 to 30% of couples that have infertility is due to the inability or the ovulation cycle of the woman. Surprisingly, we have a lot of infertility due to low sperm counts and stuff like that, which has always surprised me, because if you're dealing with an infertility thing, I've seen more women go through a lot of assessment before the husband has even been checked to see what the nature of the sperm. And really getting a sperm sample is much easier and cheaper to analyze than going through all of this other things there. But one of the drugs is basically clomiphene. And clomiphene actually acts as an anti-estrogen up at the hypothalamus. And what it does is what clomiphene is going to do is it's going to increase the pulse frequency. Again, it's not making a sustained release of luteinizing hormone. It's increasing the pulsing. As a side effect, or as a side note, we did some work with agriculture along this line, not using clomiphene, but we were looking at cattle to see about modifying this LH frequency. And they were doing it because by increasing the LH frequency, LH spike frequency, it increased the number of calves that could, the incidence of calving, and it was a significant economic improvement. But we were actually looking at things that could alter pulse frequency of the LH with regard to that. This clomiphene typically works better in women that their estrogen concentrations are normal. When you got real low estrogen concentrations or real high concentrations, this doesn't work well. Generally, this is pretty well tolerated, but occasionally there is some uterine bleeding that has been reported. Just one other thing about this, a lot of individuals we see with regard to, this is after ruling out that there's any other cause for this infertility. So, for example, this is not going to help if the male has a very, very low sperm count, or that the sperm are very weak and are not able to get, up into the reproductive canal. It's not going to work if there's some other component that may be inhibiting ovulation. So we have seen, and just go through these slides a little bit quickly, we do so that one of the things that we see is that we do use sex hormones sometimes, or reproductive hormones sometimes with cancer chemotherapy. We always have to be careful with regard to if we have an estrogenic responsive tumor, we don't want to put estrogen in. But we've used drugs like tamoxifen, and some of these are basically, a lot of these are designed to reduce estrogen level. We want to be careful about endometrial cancer, because if you have prolonged unopposed estrogen, that can increase that, but we can sometimes treat with progestins. And so there's a number of ways that we can use these hormones in certain cancers. And also, in a little bit, we'll talk about these estrogens are going to be used, or have been used quite frequently, in prostate cancer to sort of reduce the testosterone effects. I've mentioned osteoporosis already, and what we do is, like with osteoporosis, we have reduced bone mass or volume. We know that both males and females, as they age, you lose bone mass. And basically, in women, we see that during the perimenopausal period, it seems to start being accelerated. So the idea is, by using the estrogen, again, it's more effective if used ahead of time as a preventative, more so than afterwards, although we do get some help. So there's been a number of studies that have demonstrated that that estrogen can actually decrease the rate of bone loss, and as a result of that, we have fewer incidences, or the incidence of fractures in the spine, the vertebral column, in the hip and the wrist. Those go down quite a bit. So you're more prone as you get older, women more prone. One of the things we always are careful about is, if we're working with women, is we want to make sure specifically that, that we are trying to monitor osteoporosis. We want to be very careful about any drugs that we give that could make them be susceptible to falling, that they're aware of that, and that we warn them to make sure to be cautious of that. Now, this next disease creates a major issue. I think one of you mentioned that your wife had endometriosis. This disease is a fairly common disease that we see in women, and one of the things is that this disease can really, really affect quality of life. So what happens here, and I think we covered this when we talked about the reproductive tract in clinical medicine, is what we have here is that we have ectopic endometrial cells. Endometrial cells are basically the cells that line the uterus, okay? But in some individuals, we have these cells are outside the uterus. They're at various places. They can be up around the intestines. They can be in the abdominal cavity. They can be on other portions of the reproductive tract. And what happens with these is, every time there's this hormonal cycle that occurs, even though these cells are located outside the uterus, they basically respond to the hormonal milieu. So what's going to happen is, basically, when the estrogen starts being secreted, just like the uterus starts, growing and everything like that, these cells grow also. And then when the estrogen drops, then basically the uterus sheds its cells, these other cells shed too. So one of the problems is that the growth and shedding of these cells can be very painful, depending on where they're at. And another thing is, they can set up for a lot of scar tissue. They also increase the risk of ectopic pregnancies. It's possible for an instance where that, instead of a fertilized egg embedding and implanting into the uterine lining, may actually embed and form in one of these areas where these endometrial cells are. So you can get an ectopic pregnancy, which can create a lot of problems. So what's happening is that every month you're having this surge of estrogen, which then causes these endometrial cell implants that are outside the uterus to proliferate. And then when the estrogen drops, then they shed. And so this shedding of these cells can produce a lot of pain. The other thing, you can get a lot of scar tissue that forms. And in fact, that's one of the concerns that happens down the road is a lot of women with endometriosis, there's a concern of if they do get pregnant, one of the concerns is that they could have an ectopic pregnancy. The other thing that can happen is sometimes this endometrial cells form so much scar tissue that they prevent the normal passage of the fertilized egg. Excuse me. I was getting the hiccups. So what the goal is for these individuals is to try to produce a hormone-poor environment, particularly low estrogens. Therefore, you don't get as much growth of these tissues there, and that's what's the improvement. Okay, so there's several things that have been used. We've used a drug called danazol, which is the one I want to focus on, but we've also used progestins. We've also used gonadotropin-releasing hormone or some analogs of that. The idea with the gonadotropin-releasing hormone, by using those, you prevent you prevent the spikes and so forth, and it can inhibit the estrogen release. So danazol, what it's going to do is danazol is going to inhibit the luteinizing and or the follicle stimulating hormone surge. Okay. We also know danazol can inhibit the enzymes that synthesize the steroids. So we got two things happening here in particular. Is one, we're interfering with the LH-FSH, which is a signal for releasing estrogen, if you go back to what we covered yesterday. And B, what we see is that we're going to reduce the amount of steroids, which includes estrogen being produced. Danazol can also, a third property can be, it can actually interact with the androgen receptors, which is the ones that are sensitive to testosterone. It can also interact with progesterone. So what happens with danazol is it produces amenorrhea. And so by decreasing the periods, basically that relieves the pains, and but it basically does not drop the gonadotropins or the estrogens, the basal concentrations there. Pretty much prevents the surge and the release there. We have a large number of patients that take danazol, and danazol basically, we see that a significant number of patients respond pretty well to this. Typically, we see a pretty good response somewhere between 3 to 12 months of therapy. Okay, so that's pretty good effectiveness, if you will. However, the downside of this, although it's very effective, the downside is that a lot of the patients don't like the side effects. Okay, one of the things they do, most all of them will put on weight. Some complain of muscle cramping that can occur. But probably two things that probably bothers, I would say, although it's not in red, I would say weight gain is one of the major concerns. But the other thing is virilization. They tend to grow hair. And a lot of times they grow facial hair, and it can be sometimes fairly significant. But the other thing, especially that you need to be aware of, is that these patients can have some emotional lability. So they may have a lot of mood swings. And that is probably a big concern that we have. The skin gets oily. That's probably it. The virilization, the weight gain, the oily skin, all of those are associated primarily with probably the androgenic components there. And we have to monitor them for their blood pressure. The nice thing is most of these effects are, if they stop the drug, they go away. The downside of it is we lose the effectiveness of the drug. So with danazol, it works pretty well. The biggest issue is whether the patient will tolerate the side effects. And again, one of the things we see is that putting weight gain, virilization, oily skin, that can be a significant downside to the patient, that it makes them very unattractive. And then also the emotional lability. Some women have come off, the drug has worked well, but they've come off because they just said the mood swings are just too much for them to handle. So some of the antiestrogens, we talked about clomiphene. Most of these effects are dose related, so that's good. We see some hot flashes that can occur. We may get in some of these antiestrogens some ovarian cyst. Breast tenderness is fairly common. Depression can occur. A lot of times when we've gone through fertility, people end up with not getting one baby, but end up with multiple. They increase the chance of getting twins and even triplets. And again, these are just mentioning to you, these are considered anti-estrogens like tamoxifen. Tamoxifen works pretty well for things, and it's usually tolerated pretty well. So that sort of goes through the estrogens that we have here. So let's move to the other side, which is the androgens. So we're moving to the male side. Realize that both males and females produce estrogens and androgens. We see the estrogens more prominent with the female. We see the androgens more prominent with the male. From their effects, the androgens basically stimulate hair growth. They stimulate spermatogenesis. And in both males and females, we get increased body hair growth. We see bone growth, muscle development, and we also see increased erythropoiesis, which is increased formation of red blood cells. So androgens do that. In fact, a lot of the athletes that have used performance-enhancing drugs, their big thing is the muscle development and the erythropoiesis. The erythropoiesis makes more red blood cells, which theoretically will carry more oxygen and can improve their endurance. But if you produce too much erythropoiesis, then your blood gets sort of sluggish and you don't have as good a movement. What we basically see, if you're looking at serum testosterone, which is one of the androgens that we monitor quite frequently, is we see that in the male, we're seeing that during gestation, we have some increases and decreases, but basically we see at infancy things drop real down, and then we see a surge of testosterone occurring at about puberty. It probably peaks somewhere in your 20s and then starts tapering off when you are after your 20s. And so there's a significant reduction. Now, the reason I mention this is because one of the reasons that we see a lot of androgens prescribed is because we see a natural age-related decrease in testosterone levels. And many people believe that that decrease in testosterone levels is what is associated with a lot of the negative effects of aging, that you basically don't have as much energy, your libido goes down, your sex, your ability to maintain erections goes down, all these different things. So the idea is one of the things, and we see that it peaks in the 20s and starts declining afterwards. So their idea is that when you're old, you have all these problems, and when you're old, you've got lower testosterone. So therefore, if we increase the testosterone, then we'll make you young again. Now, first thing I'll mention to you is these drugs, these androgens, testosterone supplements that people use, or not supplements, testosterone drugs. Basically, we do not know what the optimal level is in older people. So when they are treating testosterone deficiencies, they're actually using the testosterone levels that you see when a person's in their 20s. So that's what their target is. So when you look at testosterone synthesis, we covered this a little bit, but basically we start off with cholesterol, as you can see up here. We get pregnenolone. That was what we saw in the thing other there. Jason, that's an interesting thing. What we need to be is feeling like we're 20 again, knowing what we know now, and having, the resources, economics, and so forth that we have. Although you keep thinking about if you had your money and everything, and what you knew now, how much more trouble you might get in. So that would be the concern. I had a friend of mine that as he was retiring, he says, they've got this economics all messed up. He said, I'm retiring and I've got really more money than I really need. I mean, he wasn't real rich. He wasn't rich, but he was, very comfortable. And he said, when I needed the money was when I was young, trying to buy a house and trying to raise my kids. He said, so what we need to be paid is when we're young, we need to be making, 2 to 3 times the salary that we were hired at. And then it decreases as we age, because we actually leave less money. I said, good luck in trying to get that passed. That is not going to happen. So anyway, going back to the testosterone. So pregnenolone it actually goes to progesterone, and then it can go through and we get androstenedione, which then shows up as testosterone. So a couple of things here. We have several intermediates, and also keep in mind that we have, in the process of doing this, we are making progesterone, which is somewhat considered a female hormone. And then if you see it broken down, notice here, testosterone, when we look at it, gets broken down to estradiol, gets broken down to androstenedione, which can then be used to make more testosterone. We see dihydrotestosterone is a metabolite, and these ultimately get conjugated with glucuronides and sulfates and are passed out through the urine. And by the way, I'm not asking you any of these pathways. I mean, the biggest thing I want you to know is that testosterone, both the male and female hormones, are very closely related structurally. And secondly is that we can get, female hormones formed from male hormones and vice versa. So let me just cover this slide, and then we're going to take our first afternoon break. So steroids were actually developed in the 30s to really treat what is known as hypogonadism, okay? What we thought was hypogonadism is basically that the gonads, male gonads, were not functioning, so we had lower levels of testosterone. So these were designed to supplement the endogenous level. So what we have seen the steroids used is in individuals where there's delayed puberty. So if you remember the graph a minute ago, we had that big surge at puberty. It has been used sometimes for treating sometimes of impotency, although sometimes we do see that steroids, when given, can produce impotency. And we've also seen it used for body wasting diseases, a lot of times with things like HIV and some other, like cachexia. Some of those have been used to try to increase muscle production. But the majority of the use has been primarily hypogonadism. So, and we've had a whole, we don't see these ads very commonly anymore, but we had mainly because the drugs went generic. But if you remember, there was a whole number of ads that were promulgated a few years ago about low T. The idea that it's just a number, and basically what's happening is that you are decreasing, that as you age, your testosterone levels go down. And so we can supplement them and make you feel young and make you, more sexually active, or get your sex life back, you get your energy back, and all these other things. So, and in fact, one of the things that they try to do is it's not that you have anything bad. The testosterone is just a number. That was the whole aspect of the commercial was, it's not that you got any disease, really. It's just the number. Your number is not where it should be. And so we saw that. All right. So let's come back at 20 after the hour, and we are going to pick up on the continue on the steroids. Okay. All right. So when we're moving, like I said, to the androgens, and there's a couple of issues associated with this. Is that one is that we have a lot of different androgens that are available. These androgens, these are the male steroids. And so actually, if you look at what's available worldwide, there's probably more than 100. Some of them are oral. One of the ones that we see used quite frequently, also in addition to the fact that they are used to treat some of these conditions, we do see some of these steroids are used, basically abused. So stenozolol, which is one of the big ones that we see used. And probably for hypogonadism now, we are seeing more of the topical, the things like Axiron. These are the ones that basically they're applied underneath the arm, and they're applied as a topical gel. We do see people still using testosterone in the injectable forms. For example, testosterone cypionate, which is the depot testosterone. So you inject it in a depot form, and then it diffuses out. So we have a number of these drugs that are there. And as far as being abused, we also see that some of the drugs, like, for example, at the bottom here, Boldenon, which is actually used for horses, we have seen those used. And so those are some important things that that we see, or I should say, that are being abused pretty frequently. So All right. Can you guys still see the slides that I've got up? Yep. Okay. It was my screen was looking a little weird here. So what we see is that in addition to the prescription medications, what we saw is there's also some supplements. A lot of times these supplements were available over the counter. They weren't as close, again, they were not closely as regulated by the FDA. Many people will take these thinking that they have some sort of anabolic effect. So we see things like dihydroepiandrosterone, which is DHEA. Androstenedione was the one I think Mark McGuire used, which on the streets known as Andro. And as I've said earlier, is some of these, when we're going through the different metabolisms and everything like that, some of these can actually be converted to testosterone. And in some instances, they may actually be converted to estrogen or progesterone. We have not got, as long as these drugs have been around, one of the things is that we have not seen a lot of studies done with very, very large doses. In fact, a lot of our information is actually sort of anecdotal that's come back from people that have been abusing the steroids from a standpoint of that. And, we're going to cover a little bit about the abuse of steroids while I'm covering it here. So the biggest thing is most people believe that it improves their performance. This falls under the category of what they PEDs, which is performance enhancing drugs. And Eddie, you're right that basically there was GNCs. A lot of health food stores were carrying things like Andro and stuff like that. We did find in some of those supplements that they actually did have steroids in them that was undeclared drug products. Interestingly, with steroid abuse, we also see that they can potentially improve performance in sports by bulking people up. I've seen some of the wrestlers, the world heavyweight wrestlers that we see that is more of an entertainment type thing. But some of those guys were, former college football players that when they were given the, you see them leave college and then you see them show up in the wrestling world and they bulked up unbelievably, which pretty sure that they have, basically used steroids for that. One of the things, not only do you increase muscle size, but another thing that occurs is it actually can reduce body fat. Now, if these substances are converted to estrogenic substances, then you may actually get a greater deposition of fat because one of the things that estrogen does is it increases fat deposition in the thighs, the buttocks, and the breast areas in particular. One of the things that came up with regard to steroid abuse was that some people that were abusing this, basically they had what is known as muscle dysphoria, which basically this is a distorted body image, and it's a behavioral. So, and it occurs in both sexes. We see men tend to think that they look small and weak. Women tend to think they look fat and flabby. And so the idea is that using steroids will reverse this. It will increase the size and the strength in males, and it will increase the muscle tone in females. We see that, and steroids is one of the things that they do. Again, we can sometimes have a problem when they're abusing the drugs and basically they think they're using an androgen, and the androgen gets converted to the estrogen. There's a number of things that have come out, just cover this pretty quickly, is there's been some studies and they interviewed male weightlifters and that had self-reported that they had abused steroids. And in the interviews, and I don't know how many they actually interviewed, can't remember off the top of my head, but about 25% of those individuals said they had memories of childhood physical or sexual abuse. They interviewed women weightlifters, and they saw that twice as many of those who had been raped reported using the anabolic steroids. Those weightlifters, women weightlifters, thought that by increasing their bodybuilding activities and as well as taking the steroids, that basically that would increase their size and also would their strength, which would discourage any further attacks or abuse. So that has come in there also. And actually, Najib, an interesting thing you say there, because I have looked at, different, in part of the drug abuse class I teach in pharmacy, and also do some work with the Athletic Association. Interestingly, we do see that of substance abuse in a lot of colleges, that probably, when I ask who probably uses more drugs for performance enhancing in the college level, and typically baseball is the sport that we see it. Most people will say football or football or basketball, and we do see some use there, but for the most part, we see that in the baseball. We tend to see much more prominent with that. Hold on one second. Let me see if I can. The problem with nice weather is that people go walking down in front of the street. I've got a pasture in front of my, across from my house. It's not my pasture, but it's very nice. But the problem is people go walking down the front of the street, which my dogs start barking. The Yorkie is at the front window, so she barks, and then it travels back to everything, which the other dogs are not, they can't even see anything, but it's sort of like, oh, she's barking, means I should bark. So, Jordan, you're going to have to send me a picture of your South African Mastiff. I'd love to see him. One of the things we saw with steroids when people are abusing them is that there's a process called stacking. A lot of people do, it's called pyramiding or stacking, and they think that this is a safer way to use the drug, which there is no science for this. The idea is that different steroids would interact in a additive or synergistic manner. I would say we would agree with that statement, is that when you have these, when you increase or change these, use the same steroids acting on the same receptor, yeah, they're going to be at least additive, if not synergistic. But the point becomes is that they think that this is a safer way to use it, and there is no way to do that. Let me put one dog out because he's going crazy. Had to unleash the hounds to the backyard. So what happened is people would think when they're using this is it's interesting that they recognize that steroids could have some potentially negative effects. And so the idea is that by stacking these, their idea was they would have additive or synergistic effects, which, like I said, we agree with. What we don't, where there's no scientific basis of it, they think this is a safer way of doing it. Sort of like doing combination therapy that we do, medically. But the problem with that, with combination therapy, we're using drugs with different mechanisms of actions. And what they're actually doing is they're mixing different steroids, which are still going to be acting on the same receptors. And their concept is you mix between oral and injectable. And so the reality of it is you're really changing how you're giving the drug, but not changing the dose or anything. And in fact, sometimes they'll mix veterinary compounds coupled with those that are approved for human use, like equipoise they'll use for one of the veterinary compounds. The pyramiding is where they're basically dosing in cycles. So the stacking is where they're using multiple drugs. The pyramiding is where what they'll do is they typically do a 6 to 12 week cycle. So they start with low doses and they're stacking them. So using a combination of oral and injectable. They'll slowly, what they'll do is they'll increase and then they will decrease the second portion, and they go to a period where they're getting zero drugs. So, and then many times, basically the idea is that they go for one cycle, one portion of the cycle with no drugs. And the person still is training, doing the body, weightlifting and so forth. But that is the perception that the body can adapt to the high doses and recuperate. But again, there's been no scientific basis on that. So it's been one thing that's sort of accepted in the gyms that or places that they're doing this. So when we look at adverse effects is when you look at a lot of it before we started using testosterone, the long-term effects that we were seeing, really it came down, like I said, from these anecdotal reports. Overall, the incidence of life-threatening effects appears to be low, but there is the recognition that a lot of the serious side effects could be either under-recognized or under-reported, especially when some of these individuals are using these drugs illegally. There was an animal study, which this is sort of an interesting one. So with the animal study, what they did was they took a bunch of mice, male mice, and they gave them doses that would be comparable to what they saw being abused on the street by abused by human athletes. And they gave it to them for about a fifth of their lifespan. And the reason you do mice there is because mice have a relatively short lifespan. And what they saw is that the animals that were on the steroids, they basically saw there was more premature deaths. So we've had studies like that. So it doesn't give us a lot of information with regard to long-term use. What we do know, the adverse effects are for males, infertility. This is sort of an interesting thing because a lot of males take this to increase, think they're going to become more virile, more, and so forth. It increases their sex life and everything. But what we actually see is that the additionals can be one of two things. We could be converting some of it to estrogenic compounds, which may decrease it. And it may be simply, since this is a feedback mechanism, by using the drugs, is shutting down the feedback and may actually producing a state like that. We have seen gynecomastia, and in fact, that is well recognized with people that abuse drugs. The gynecomastia pretty much is, there's even specialists that train or that treat only weightlifters and athletes. They advertise in a lot of different trade magazines about that they can surgically correct the gynecomastia and without interrupting the individual's training cycle. We've seen atrophy of the testicles. And another thing is male pattern baldness. With females, we've seen reports of enlargement of the clitoris, increased growth of body hair, and also male pattern baldness. Now, these side effects may be irreversible if they're continued use, and even with short-term use, sometimes they may not be irreversible. One of the things that we sort of preach to the athletes when I'm doing talks on them about that is that we see that in particular, they're more prone to injury, particularly tendon rupture. What appears to happen is that basically the muscles may simply outgrow the tendons. And so, especially with an athlete putting greater stress on the tendons, it can pop the tendons. It can cause short stature. One of our biggest concerns has been that there's an increase in potential for myocardial infarction and left ventricular hypertrophy. Many of you probably know some of these testosterone derivatives. There was actually lawsuits that came out that were promoting or basically going after people that were the drug companies, because individuals that were taking these testosterone supplements were not told or were not really screened or told to be screened for increased chance of myocardial infarction. There have been reports of potential liver cancer. What we do see is also a condition called peliosis hepatitis. What happens here is that on the liver, there's these cysts that develop that become filled with blood, and sometimes they can rupture. Many of the individuals that take the steroids will complain of acne, cyst acne cyst, and oily skin and hair. Very common. We see that even in, with women that are taking androgenic type hormones. One of the big things, and this is something that maybe come into your situation, is that there have been reported effects with regard to behavior. Individuals have claimed that they have increased energy. They're sexually aroused all the time. There may be mood swings. A euphoria has even been reported. But also they've talked about, especially with long-term use, that they're easily distracted, forget things, and confusion. Now, some of these things may be complicated because some of the athletes that have reported these also had repetitive head injuries. And so whether some of this is related to it, or whether that the steroids contribute to it or exacerbate it or whatever, we don't know yet. A lot of people that took them basically said it didn't affect them. That was their perception. There was a small number of individuals that said that, that when they were taking high doses, it did interfere with their jobs or how they could function in society. And then there's always the question of whether addiction can occur. We don't know how many people become addicted to these. We know that there's individuals that continue to use them despite having, negative consequences. We see that some of these individuals spend a large amount of time making sure they have the drug and seeking the drug. When I say drug, the steroids. We know that some of them have reported experiencing withdrawal. The withdrawal symptoms that they have, not uncommon to what we see with other drugs: mood swings, fatigue, restlessness, loss of appetite, can't sleep, reduced sex drive, and a constant desire for the drug. So, I think that the consensus is it can cause addiction, but we still have a lot of information that's not there. The biggest thing, and I think this is important for you guys to know, one of the biggest concerns with withdrawal is that there is severe depression, and that can lead to suicide. And we do know that the depression in some users has continued or persisted for at least a year or more after discontinuation. So let's move to the anti-androgens. So what you see is that the main thing you see is like these testosterone topical administration, the idea by topical by applying underneath the arm and absorbing through the skin. The biggest thing you see is that by applying topical, there is a low level, and that this should be monitored by whoever's prescribing this. There's a chance you guys might prescribe or potentially prescribe testosterone. I don't know if it'd be on your formularies, but the biggest thing with these is that these should be monitored. You should be monitoring testosterone level on a regular basis to make sure that the dose is correct, and to also check for any adverse effects that are there. Now let's move to the next class of drugs, which are the anti-androgens. And the anti-androgens, basically, they're going to block or interfere with the testosterone or the androgens. So we can block the receptor. So we have a few drugs: flutamide, sapropterin, bicaltumide, nalutamide. Those are receptor antagonists, so they're interfering with the androgen receptor. Another thing we can do is we can inhibit 5-alpha reductase, which is an enzyme necessary for the synthesis. So by inhibiting 5-alpha reductase, we see finasteride and dutasteride will prevent the formation of androgens. We also see a couple of drugs which we've used for many other things. Ketoconazole can also inhibit steroid synthesis. Ketoconazole is actually a antibiotic. Spironolactone we've talked about as being a diuretic, potassium-sparing diuretic. They can also inhibit steroid synthesis. And then we've also seen gonadotropin-releasing analogs used for gonadorelin and leuprolide. So let's start with flutamide and bicaltumide. These are non-steroidal, so they do not have the steroid structure. They are competitive antagonists, and we see most of these anti-androgens we're using for prostate cancer. These drugs, even though they're non-steroidals, by blocking the androgen effects that decreases the androgen and it allows a little bit more estrogenic effect. So we've seen some gynecomastia that has occurred. We've also seen some hepatitis associated with it. And by the way, with the people with prostate cancer, many of the drugs that are being used, basically, since they produce more of an estrogenic environment, we often see signs or symptoms such as, basically things like breast tenderness and even gynecomastia. So when you look at these drugs, so here's just so you can see sort of a overview here. So the testes is producing testosterone, and so testosterone gets converted to dihydrotestosterone, which then binds to the receptor. So DHT is an active component here. So what converts testosterone to the DHT is 5-alpha reductase. So one of the things is finasteride can inhibit this, so that can decrease the binding to this receptor here, okay? The drugs that block the receptor, like spironolactone, cypretone, flutamide, these all actually are going to interfere here, okay? They're androgen antagonists. Now, testosterone can also go into, this is occurring in the prostate, hair follicles in the brain, but in other tissues like the muscle and genitalia, the sebaceous glands and so forth, testosterone will bind to the androgen receptor here, and that is going to, the androgen antagonist will block that. The 5-alpha reductase inhibitors are not going to inhibit that at all. So we start off with finasteride, and the idea here is that we know that 5-alpha reductase actually is going to convert testosterone to DHT, and that DHT will then stimulate growth of the prostate and hair follicles, okay? So when we have one of the things that men develop is, especially after the age of 50, is they'll start developing what is known as BPH, which is benign prostate hyperplasia. So BPH is not cancerous, but what you do get is a growth of the prostate gland that can impede the ureter. And basically, what we find is that BPH can increase urinary frequency, can make it difficult for them to empty the bladder. They're up at night going to the bathroom a lot. And so by using finasteride, what we can do is we basically shut off the stimulus for prostate growth. And so that prevents the hyperplasia from occurring. This has also been used for hair loss, because we know that stimulation of the androgen receptor will increase hair growth. And the side effects are going to be, think about, you're going to decrease or minimize the sexual characteristics. So we can get a loss of libido. We may get some erectile dysfunction. And these are two common things that will occur with most drugs that interfere with the androgens. Ketoconazole is actually, called an antibiotic, it's antifungal. One of the things put on the back of your, in the back of your brain is the conazoles. There's several. There's ketoconazole and several others that are they are big cytochrome P450 inhibitors. So what ketoconazole does is it actually inhibits the cytochrome P450 enzymes that's involved in steroid synthesis. So by taking ketoconazole, one of the things would be a situation that you are shutting that down. Arnold, I just saw your question. I am not sure. I do not know. Most of the drugs that we're seeing are going to be hormonal, and that's a good question with some of a lot of the emphasis. Like, for example, there is a big concern about this transgender medication on what drugs can occur and so forth, and also in doing these gender transitions. Many will be hormonal, and the question will be is that whether those are going to be on your formulary. Jason, you answered the question. The steroids, cytochrome P450s, are very similar to those metabolizing other drugs. One of the things I was going to say about the conazole type antifungals, all of those are usually most of those are strong inhibitors of cytochrome P450 metabolism, and we can have a lot of drug interactions, and we have to be careful about that. So anytime you're using a conazole, it's a good thing to check to see if you're going to have a potential drug interaction. Spironolactone we've talked about. It is also anti-androgenic. What it does is it inhibits 17-alpha reductase. So what that's going to do is that's going to prevent the synthesis of some of the androgens, and that decreases it. Arnold, there is a paper that I saw, and I will see if I can pull it up. I don't know if it's available to me to pull up, but I will see if I can pull it up, that talks about some issues dealing with the political environment and everything, dealing with transgender and medications, that I think it was in JAMA, if I'm not mistaken. I'll see if I can locate that paper and put that in with you guys for you guys to have. Okay, so I think that sort of, we've covered sort of a cross section of the female and male sex hormones that would be prescribed here. I know we just finished a break here, but let's do this. This will be our last break of the morning. So I'm going to pull up another set of slides. So let's go ahead and take about I've got about 8 or 9 minutes. So let's come back on the hour, and then we're going to pick up on the slide set that talks about hormones. So that'll allow me to make a change on these slides. And then when we get back, one of the things is, Aiden, you might want to take the role when we come back from the second break. So let's go ahead and take the break now, which will allow me to change over to the next slide set. And this will be our last break for this morning. We'll start back on the hour. We'll go through till to about 30, 35 minutes after the hour, and then we will break. We'll have your questions, and we'll break for lunch. We're going to start talking about. And so what I'm looking at is we are probably going to get through the hypothalamic and pituitary hormones. And this afternoon, we will get through, when we come back from lunch, we will finish those up. Then we'll talk about the movement disorders. And then we'll cover a little bit about the antibiotics. I'm going to probably jump around, but I'm going to reduce the amount of stuff I ask you on the antibiotics, which will sort of hopefully give you a little bit of relief. We'll talk about that when we get back. So, because I know I've thrown an awful lot at you guys today, and we're sort of finishing up with this. So we'll run through the antibiotic slides depending on what we've got. We may skirt through them to hit some high points there, and I will specifically tell you what I'm going to ask you about on the antibiotics, since this will be a group of drugs that you will primarily not be prescribing, but will invariably see a lot. So let's start talking about let's go ahead and start talking about the hypothalamic hormones. So if you remember back, and again, several of these slides are very similar to what you saw before. So what we find is the hypothalamic hormones include the releasing factors. So we have growth hormone releasing factor, GnRH. Don't confuse that with gonadotropin releasing factor, which is GnRH. We have somatostatin, thyrotropin releasing hormone, TRH, corticotropin releasing hormone. We have the anterior pituitary hormones, which are the stimulating hormones. So we have growth hormone, thyrotropin, which is TSH, follicle stimulating hormone, luteinizing hormone, so it's FSH and LH, prolactin, and adrenocorticotropin. Excuse me. And then the posterior hormones, we really have two. We have vasopressin and oxytocin, okay? So remember, we're going to have the hypothalamic hormones basically will cause a release from the pituitary, then will stimulate the organ, okay? Now, many of the times when we're going to use these or use this or affect these hypothalamic pituitary is when we are going to have some sort of deficiency. what we find is, let's start off with growth hormone releasing hormones. So typically what we see is that where we have an issue here is that there's not enough growth hormone releasing hormones, so growth hormones not being related. And I think, guys, he's going to do it just very shortly. He was going to come back after this break and run that. We do have and one of the problems we run into with a lot of these different hormones is that sometimes we don't have a commercial product that's available. So we do have a commercially available product for GHRH that is very similar to the growth hormone releasing hormone. It produces about the same degree of release of growth hormone. So we have actually two. One is what they've done is they've taken growth hormone and growth hormone releasing hormone, and they put a synthetic amino terminal segment of it. Okay, and that's called sermorelin. And then we also have another one, which is a analog or a very similar structure of one of the growth hormone releasing peptide 6, which is called hexarelin. The 6 is where the 6 comes in. But sermorelin and hexarelin both work effectively. They work just almost as good as the native GHRH. And so typically what we're trying to do is we are going to be replacing or trying to stimulate growth hormone release. We also will, we can use these diagnostically, but typically with sermorelin and hexarelin, these are used to treat growth hormone deficiency in kids. So what's going to happen here is the kids are not getting growth hormone, they're not growing, so we use these drugs here. Many of the effects are tend to be just very short acting and very transient. One of the things that we see is that where they inject the sermorelin or the hexarelin is, this is a fairly common reaction, is you get some flushing at the injection site, pain and erythema, so redness around it. But we also see they may have a flushing overall. They may turn sort of red. And a lot of people will complain about that. They get nauseous and, headache, and basically many complain of a metallic taste. One of the big things that we're concerned is if you're using growth hormone, is the concern is, well, what if there is some abnormal tissue? Is it going to stimulate, for example, if there's a malignancy and you inject growth hormone, is this growth hormone going to stimulate the growth of that malignancy? There is currently, we do not know that, we have no known evidence that it actually causes malignancies. But since we don't know exactly what may happen if a malignancy occurred, then it's recommended to stop therapy if there is a malignancy that's detected. So the idea would be is you don't want, the cancer to come in, you don't want to have a malignant cancer and then the growth hormone stimulating it. Somatostatin is another drug here. And somatostatin, if we use natural somatostatin, the problem is it's very short half-life, 1 to 3 minutes. So basically, there is no way to use that pharmacologically. So what we do is we have an analog of somatostatin. And again, these analogs are basically, what they've done is they've taken a structurally similar or developed a structurally similar compound. And in this particular case with somatostatin, you're actually trying to inhibit growth hormone. And so octreotide is very, very potent. It's actually about 45 times more potent than somatostatin in inhibiting growth hormone release, okay? So what we have is individuals that may have like acromegaly and some of these things where we have excess growth hormone, and what we want to do is inhibit it. Now, the nice thing about octreotide is we got a greater potency than somatostatin, than the normal thing, but we basically don't have, it's not as potent in altering insulin release, and that's a good thing. Because if it was really, really potent with causing insulin release, one of the things that we would run into would be is that we get hyperglycemia, and we rarely see hyperglycemia, and so that's a good thing there. What we find is this is not due to a difference in how the octreotide interacts with the receptor, but it's actually due to the way that octreotide distributes. It's a pharmacokinetic difference, not a pharmacodynamic difference. So what we find is when octreotide, what we use it for is basically when we have hormone-secreting tumors. Hormone-secreting tumors can occur in acromegaly. So if you remember the elephant man, he had acromegaly. So we get the big growth malformations and so forth. Carcinoid syndrome, the carcinoid syndrome can secrete serotonin. Gastrinomas can secrete gastrin. Glucagenomas can increase glucagon. And then we also we get what is called diabetic watery diarrhea. So these are all hormone secreting associated with growth hormone secretion or secretion of these other substances. And so that's so basically what it does is antagonize those effects. Now, another important usages we have is that this has been successful in control of bleeding from esophageal varices. If you think back and remember, esophageal varices are varicose veins of the esophagus. And basically what's happening there is we can have severe bleeding. We see it in alcoholics. We see it in people that are developing cirrhosis of the liver and so forth. And so we can use the octreotide to inhibit the bleeding from the esophageal varices until we can go in and fix them typically they go in surgically and band them and shut the bleeding down. The adverse effects, nausea, vomiting, some abdominal some GI effects in general. But one of the things that does occur, we have to be careful, is steatorrhea. Steatorrhea is a fatty stool, and anything that's lipid, it doesn't get, you have a loss of absorption of fat. And with steatorrhea, the stool is usually sort of a yellowish brown color and pretty rancid smelling due to the fat in it. Any lipid drugs may not be absorbed well if you're having steatorrhea because they may basically be carried out in the fat. We can have a loss of fat-soluble vitamins, vitamin A, vitamin D, vitamin E. If this is used for more than 6 months, we have had reports of gallstones occurring, and we have seen also some vitamin B12 deficiency and potentially cardiac rhythm disturbances. So we have to be careful when we're using it for longer periods of time. Pegivizumab is actually a growth hormone receptor antagonist, specifically used to treat acromegaly. Basically, what it does is it binds. The growth hormone has 2 active sites, and what we find is on one side of the growth receptor hormone, it basically binds pretty tightly. On the other side, it doesn't bind as tight. And what that does is by binding on 2 different sites, one tight, it's like putting pressure on one side and putting a lot of pressure on one side and not putting a lot of pressure on the other side. It prevents when growth hormone binds to it, it prevents the conformation change necessary to initiate signal transduction. So basically, it sort of locks in the receptor so it can't be stimulated. Somatotropin, we find that its normal actions is that it will produce growth at the open bone end plates, the epiphyses, and we see that it will increase skeletal muscle growth, and we see it also will break down lipids, so it breaks down the adipose tissue, and that's all this is part of it with growth. So we have a couple of preparations. We have human pituitary growth hormone, which is actually somatotropin. That's not used. What we do see is a recombinant, and one of the things just to be aware of is anytime we have a little R, that means it's a recombinant preparation, and if it has an H, that means it's derived from human. So we do have recombinant human growth hormone, which is called little r, little h, GH, and we do have what we have is somatropin and somatrim. What we find is the recombinant form is as effective or as potent as human growth hormone. And when we give it, what we see an initial insulin-like effect. We get a lot of uptake of glucose and amino acids that goes into the tissues, and we have a decreased breakdown of lipolysis, because basically the idea when you're breaking fat down is because you don't have enough. It's breaking it down for energy, And so when we get an increase of uptake in amino acids, basically there's no need to break down the fat. After a few hours, it actually has an antagonistic effect. And so what we see then is basically glucose uptake slows down and we see more breakdown of the fat. So initially it's insulin-like. After a few hours, it goes to a insulin antagonistic effect. So one of the things that we find is that growth hormone can produce, it stimulates the synthesis of somatomedins, and somatomedins cause the bone growth and the cartilage synthesis, and that's what occurs with GH, with growth hormone. So anytime that we're wanting to do that, we want to avoid it. Now, here's an interesting thing, especially with hormone preps and tissue extracts. Prior to 1985, what we saw was growth hormone was actually harvested from human cadavers. What they would do is they would go into human cadavers and they would remove the pituitary glands. Okay, then they would extract growth hormone, and that was what was being used. But what they discovered was that there were patients that several years after getting growth hormone developed basically a viral-mediated neurodegenerative disease known as Creutzfeldt-Jakob disease. And it was discovered that what was happening was the virus would be present or was present in these cadavers, in these pituitary glands. And so what would happen is when they extracted the growth hormone, the virus came with it. And when they gave it to individuals, basically the virus was given to them, and then they developed this Creutzfeldt-Jakob disease, which was neurodegenerative. So because of that, and this is always a concern when we are looking at human-derived or tissue-derived, is viruses in particular are notorious for sort of hiding in the tissues. And so it's possible that when you're using these tissue extracts, it always is a concern of me that I've had with people that are getting extracts, from health food stores for thyroid extract and so forth. Yes, it's a natural product, but you can't be sure that in the processing that you may not be carrying or bringing or introducing some sort of virus or organism into the body. By using the recombinant GH factors, basically there's no chance of it. So that was a big reason why people have moved it, is we moved away from the growth hormone therapy. It was interesting. I mean, it's really surprising that they were able to pick up where this occurred from, because this disease presented several years after people had been given growth hormone therapy. So the fact is, because it's several years out, this is always an issue that that we worry about from a standpoint of is this what's exactly happening, or where did it come from? So that's one of the things when we're using the recombinant forms. Basically, we are getting we're avoiding some of the potential transfer, if you will, of some of these other things. So growth hormone, and when I say growth hormone, it's the recombinant form, usually pretty well tolerated. There have been some rare instances of some intracranial hypertension, which means that the blood pressure in the skull basically increased. Those individuals had headaches, had vision changes, nausea and vomiting, but that was fairly rare. If you get too rapid of a growth, in other words, we give too fast, we have seen scoliosis occur, so some malformations in the spine. We also want to monitor for development of hypothyroidism. It has been known to produce that. And we also have seen some cases of pancreatitis and gynecomastia. Typically, what we find is that the adults actually present with more adverse events than kids. And a lot of the adults, their type of things that they've received when they receive this, they've complained of myalgias, which is muscle pain, some arthralgias. The arthralgias is joint pain. Typically, that occurs at the higher dosages. And when you lower the dose, that tends to diminish. We do see people have developed carpal syndrome associated with this. We do know that this can induce cytochrome P450 enzymes. So if you're using other drugs that go through cytochrome P450, it's possible that the induction could decrease or could create a reduction in therapy by metabolizing the drugs pretty quick. And again, anything that's a growth hormone stimulator or anything that's a growth stimulator, you do want to avoid in people that have malignancies. TRH, don't have to worry about too much. It's available as a drug called proterolin. It will stimulate the production of T3 and T4, mainly because TRH is going to stimulate TSH, which will then stimulate it. They have used this rarely to test thyroid function. What you're doing is by giving TRH, you're going to test the ability of the anterior pituitary and releasing TSH, and you're also testing whether the thyroid gland can release T3 and T4. A few toxicities there. People complained or said, again, you're giving this fairly short term, and people have complained of, reported they have the urge to urinate, metallic taste in their mouth, some slight changes in blood pressure. But again, not going to see this much. And TSH, we use that sometimes as again, diagnostically to determine if there's potentially a thyroid tumor. And there's an analog and a recombinant product of these. So what it does is it'll bind to the TSH receptor. That increases the iodine uptake, and that results in an increased production of thyroid hormones and thyroglobulin, which is the protein that's going to carry it. And we have seen in some individuals that they develop hyperthyroidism. Another product, corticotropin releasing hormone. We have a human product. We have a sheep product. The sheep is very similar to human. The thing about the sheep is that it is more potent and longer half-life. So, this is where we make the corny joke that it's really bad versus the human. So what CRH is going to do, corticotropin releasing factor, it stimulates the pituitary, and basically that causes the release of ACTH. That results in the adrenal cortex basically reducing cortisol and producing androgens. So this one is only used for diagnosis of Cushing's disease. Then ACTH, you may have a little bit more discussion about ACTH when we talk about more from its diagnostic aspect, when you talk about depression. But ACTH will stimulate the synthesis and release of cortisol from the adrenal gland. Can also stimulate glucocorticoid release, mineralocorticoids, and androgens also can be stimulated. And we get some increased skin pigmentation if they use it chronically, and it will stimulate both the hypertrophy and hyperplasia of the adrenal gland. This one is used for diagnosis of adrenal dysfunction. Really has no advantage over glucocorticoids, which we see used more frequently. And it can produce some hyperandrogenism basically by stimulating the androgen production. Okay, so let's we'll do gonadotropin releasing hormone since we've talked about it a little bit, and then that'll be a good place for us to stop for you guys to take your questions and then go to lunch. Okay, so GnRH. In order to get LH and FSH, you've heard me say this multiple times, it's got to be pulsatile. Okay, so if you actually give sustained GnRH, so if you give like an injection so it's pulsatile, then it will release LH and FSH. If you give a sustained release, then basically what that's going to do is that's going to suppress it. So sustained gonadotropin releasing hormone actually inhibits the release of FSH and LH, and that will actually produce hypogonadism. So what we use pharmaceutically, GnRH, it's synthetic. Okay, we don't use the natural. But what we found is that basically there's a lot of different analogs that are more potent than the synthetic GnRH, and they're longer lasting. So we have drugs called leuprolide, neferilin, buserelin, goserelin, hisvelin. These are all analogs of GnRH, and they're used for the diagnosis of hypogonadism, but we're also seeing them used more to treat infertility, and we do that by administering pulsatile doses, okay? What we find is we see the sustained administration is used for prostate cancer, endometriosis, polycystic ovarian syndrome, and precocious puberty. So what you're going to see with the pulsatile, it increases fertility because it increases the estrogen and progesterone release, whereas sustained administration is going to suppress the system. So in general, the GnRH, which is known as gonadorelin, we're going to basically see some headache, nausea, flushing, lightheadedness, not anything really severe. When we look at the GnRH analogs, which are primarily, again, a lot of these are used more frequently for suppression, individuals they have complained of depression, something you need to know if they're getting this. They may have hot flushes, sweats, headaches, breast atrophy, decreased libido. These are all very common things. And we do see in women in particular that within the first couple of months, there may be some development of ovarian cysts. Typically, they will resolve in 6 weeks, but if they don't, you may have to stop therapy. One of the big concerns is osteoporosis. So if you've got an individual that is older woman or maybe already has predisposing conditions for osteoporosis, you want to avoid that. The leuprolide and goserelin, again, these are analogs too. One of the things, since we do use them in prostate cancer, these actually may precipitate pain in men that already have gotten bone metastases. So the prostate cancer is metastasized, and this can be some fairly significant pain. And if they have already some urinary obstruction, that can make it worse. The biggest thing is that by suppressing the testosterone levels, they may actually start developing hypogonadal symptoms. And because you're basically shutting down or decreasing the androgens. All right. Let me finish this slide, and then Aiden, if you want to put up the questions and everything, we'll go from there and we'll break for lunch. All right, so the antagonist we've talked about, again, the GnRH agonist, if given long-term can actually, given as a sustained injection can actually produce, an antagonism. So what they do with the GnRH antagonist is this one actually, Cetralix, is a synthetic compound, and it binds to the pituitary GnRH receptors. That's why it's blocking it. So what they do is they've used this for in vitro fertilization to try to prevent premature spontaneous ovulation, but we do see this one used quite frequently for endometriosis. And by blocking the GnRH receptors, it prevents the gonadotropin releases, and we get an effect there. So we see it used for endometriosis. Typically we'll see danazol started. If the danazol doesn't work, we see one of these drugs used here. All right. So when we come back from lunch, we will start talking about some of the gonadotropins, FSH, LH. We'll talk about those. We'll finish up on this and then start with the movement disorders. So Aiden, if you would like to go ahead and set up the exam. And by the way, I'll go over the exam questions when we get back from lunch. So guys, complete the exam. Look back over the material that I've covered today and even tomorrow. That's sort of your little bit of homework assignment today to make sure that if you need me to go back over something, let me know, since we're going to be, since I've given you a lot of information here. Okay. All right. So I'm going to sign out. You guys do the quiz, look back over the material, see if there's anything else you need me to cover, go back over again, and I will see you guys at 1 o'clock.